So, good evening, everyone. Am I audible?
जी मैम, जी मैम, जी मैम।
Yes, ma'am.
वेरी गुड। तो
Good evening.
अभी हमारे लिए बहुत ऑनर की बात है कि भारती कश्यप मैडम जो चेयरमैन साइंटिफिक कमेटी है झॉस के, वो हमारे साथ हैं। और मैम का सजेशन था कि हमारी जो ये टीचिंग प्रोग्राम है वो झॉस के अंदर हो, तो एंड स्पेशली हम फोकस करें ऑन प्रिफर्ड प्रैक्टिस। सो इट्स वेरी नाइस कि हमारे साथ सारे पीजी स्टूडेंट्स भी ज्वाइन किए हैं फॉर दिस टीचिंग प्रोग्राम। एंड ऑल्सो मैम एक्चुअली फ्रॉम डिफरेंट पार्ट ऑफ झारखंड जो ऑप्टोमेट्रिस्ट हैं, जो कि ग्रास रूट लेवल में पहले पेशेंट को देखते हैं, तो वो लोग भी इस पीजी प्रोग्राम में पार्टिसिपेट करते हैं। सो मैम, आई थिंक a small motivation sentence from you to all the participants. Okay, thank you so much. So अभी हम लोग प्रीफर्ड प्रैक्टिस प्रोग्राम, जो प्रीफर्ड प्रैक्टिस होता है वो क्या चीज होता है, उसमें एक बार हम बता के देन आगे कुछ क्वेश्चंस है उसको आपको आंसर देना है। सो प्लीज बी क्विक। मैं आपको शेयर करने वाली हूँ अभी अपना स्क्रीन। सो ये प्रिफर्ड प्रैक्टिस पैटर्न पीपीपी, ये चीज जो है इसको पहले अमेरिकन एकेडमी ऑफ ऑफ्थेल्मोलॉजी ने इसको प्लान किया कि इसको ऐसे शुरू करना चाहिए और जिसको कि अपडेट होना चाहिए every 5 years. So this is one evidence-based recommendation. What should be done based on कि जितने important study है उनके ऊपर, so that कि हम quality of care को improve कर पाए. So that does not mean कि this preferred practice will be applicable to each and every patient. It has to be individualized as per the situation. Okay, as per the individual patient. But in most of the patient हम इस practice pattern को use कर सकते हैं, right? Okay, so now let's come to the first question. When you will screen for glaucoma?
Dr. Anindya, I'm not able to see your slide.
Is that so?
So
Is
it
anybody,
problem with
everybody able to see my slide?
No, ma'am, I'm also seeing
No,
just
ma'am.
the downloads, the list. It's not opened yet.
Okay, so I'm just resharing once again. Share. Are you able to see now?
Yes, ma'am. The screen is visible.
Okay. So it is the PPT now. In the PPT page
The
only I'm
PPT
there.
No, ma'am. The PPT is not visible.
Oh, okay. Wait. Not, visible still now?
No,
PPT
Dr.
not
Anindya.
visible?
No,
No?
ma'am.
No.
Is the sharing is stopped or not stopped?
Stopped, ma'am.
Now the sharing is stopped. Okay.
Ma'am, screen is sharing, but the PPT is not opening up. Screen share is happening.
Now can you see?
Yes, ma'am.
Now can you see?
Yes, ma'am.
Perfect.
It's there.
Very good. So today we are going to focus on preferred practice pattern, that is for glaucoma. So Dr. Dibya, are you ready with your preferred practice pattern and your topic?
So I'll be discussing about the pathological myopia. So basically, I
Okay.
will be discussing only pathological myopia today.
Okay. Shreya, let me know after 15 minutes so that Dr. Divya Prabha can go ahead for her. Okay?
Okay, ma'am.
Fine. So this is what we have already discussed. So let's go to the first question. So everybody get ready for the answer. I will be typing whatever you will say. When you will screen for glaucoma, be quick. What is your common practice in day-to-day practice when you will screen for glaucoma?
गुड इवनिंग मैम।
Good evening, beauty. Go ahead. कब करोगे स्क्रीनिंग?
मैम स्क्रीनिंग के लिए सबसे पहले हम लोग पेशेंट्स का जब हम लोग टेस्ट करते हैं तो अगर पेशेंट्स का हाई मायोपिक है या फिर हाई हाइप्रोमेट्रोपिक है या एस्टिग्मेटिज्म है पेशेंट्स, तो उस कंडीशन में हम लोग एक बार आईओपी मेजर करेंगे और पेशेंट्स का हम लोग अगर
Okay,
पेशेंट्स
so to summarize, when there will be associated risk factors, then go ahead. Next.
और मैम चश्मे का पावर बार बार चेंज कर रहा है तो उस टाइम फिर ग्लूकोमा चेक करेंगे मैम। चश्मे की
Okay.
पावर हर 3 मंथ के बाद चेंज कर जा रहा है, रिपीट चेंज हो रहा है तो फिर ग्लूकोमा टेस्ट करेंगे मैम।
हर 3 मंथ नहीं, फ्रीक्वेंटली चेंज हो रहा है तो हम
Glaucoma
हाँ
test.
फ्रीक्वेंटली, हाँ जो भी, हाँ हाँ
Just a minute. Just a minute. Glaucoma test और glaucoma screening में difference होता है. Glaucoma का test confirmatory होता है. Now our question is on glaucoma screening.
मैम फैमिली हिस्ट्री इम्पोर्टेंट है।
तो वो रिस्क फैक्टर में आ गया। आप ग्लॉकोमा स्क्रीनिंग का रिकमेंडेशन क्या है? दैट इज द क्वेश्चन।
आई का प्रेशर अगर बढ़ता नहीं होता,
आई का प्रेशर बढ़ जाएगा तो फिर आप कंफर्मेटरी टेस्ट में जाओगे। स्क्रीनिंग का
मोर देन 40 इयर्स
प्रैक्टिस के हिसाब से स्क्रीनिंग का क्या रिकमेंडेशन है? कब स्क्रीनिंग होना चाहिए डॉक्टर गुलाटी?
के लिए हाई
मोर देन
स्ट्रेट
40 इयर्स
हाई स्ट्रेट
वेरी गुड। above 40 years. Go ahead. How much is the duration? कितने ड्यूरेशन में करेंगे?
कुछ नहीं, चुप।
What should be the कितने फ्रीक्वेंसी में, मतलब कितने फ्रीक्वेंसी में हमें स्क्रीनिंग करना चाहिए? क्विक, जल्दी जल्दी।
3 months, 3 to 6 months.
No, 3 to 6 months will go for if
Ma'am.
anybody has the higher risk to develop glaucoma. आपने रिस्क
yes,
सारा
ma'am.
स्क्रीनिंग कर दिया और उसमें बहुत हाई रिस्क सस्पिशन है, तब जाके आप 3 मंथ में आप उसको फर्दर देखोगे। बट इन ऑन जो बताया गया एवर 40 years,
ईयरली
तो दिस
मैम 3 hours
every 1 to 2 years
यस मैम
for
ईयरली
40 years. But अगर if above 65, then above 65, then
Ma'am,
it's yearly.
6 months
6 months
Yearly. Okay. If screening करते हुए आपको लगा कि yes, there is some problem, there is some doubt, then only you will ask for a more frequent screening. Good. Okay. So go for the next question. When glaucoma progression can be seen with normal intraocular pressure? Be quick. When glaucoma progression can be seen with
normal tension glaucoma
intraocular pressure?
normal tension glaucoma
Very good. NTG. What else? What else? Glaucoma progression is seen, but the intraocular pressure is normal in your
low
practice.
CCT low central corneal thickness
Okay, very good. Who else?
बेसलाइन टेस्ट
Where you will find normal pressure, but the progression is there.
विजुअल फील्ड
Anyone else?
any
RNFL.
I'm asking, you are seeing progression but the pressure is normal. ऐसा कौन से situation में होगा?
Any refractive surgery में done.
Glaucoma.
Normotension glaucoma already said. What else? कब हो सकता है?
Ma'am, if somebody is on anti-glaucoma medication and hence maintaining pressure, still that patient can have progression.
Absolutely. So if your target pressure is not achieved, what you are saying is target pressure is not achieved. It may be 18, you will find, okay, it is normal, within the normal range, but still there is progression. That means the target is not achieved. Okay, what next? Pressure is normal, but you are seeing progression.
Ma'am, false positives in visual field. I don't know.
False positive.
Like inaccurate visual field testing.
Okay, inaccurate, not reliable.
Not reliable.
So that means progression itself is not reliable.
Yes, ma'am.
Ma'am,
Okay.
missing the history of refractive surgery previous and if done.
Okay, that will come under CCT law. Okay, so suppose refractive surgery is done, then that means CCT is less. Central corneal thickness is less. When else? Dr. Irshad, when you will find this condition, the patient will be presenting with a low intraocular pressure, but it is still progressing. Non-compliance. See, when the patient is coming to you, they are using medicine.
Open angle glaucoma, ma'am.
ओपन एंगल ग्लॉकोमा में हमारा क्वेश्चन जो है कि कब प्रोग्रेशन होगा बट प्रेशर विल बी नॉर्मल. ओके, कैन यू अंडरस्टैंड नॉन कॉम्प्लियंस हाउ कैन कॉज? कि आपके पास जब भी पेशेंट आएगा वो मेडिसिन डालेगा, बाकी टाइम ना नहीं डालता है. ठीक. व्हाट आर द अदर कंडीशन?
Ma'am, we have 4 more minutes left.
Okay, so I'll be completing one question, then I'll give handover to Dr. Dibyaprabha. So for example, I'm telling you, when there happens IOP spikes, intermittent. When IOP spike intermittent happens, in which condition?
If we
So whenever you are checking, कि आप अभी check कर रहे हो intraocular pressure, now it is normal, but when you are not seeing, there is a spike in intraocular pressure, like pigment dispersion syndrome. Pigment dispersion, not necessarily always the pressure will be high. Second, even chronic angle closures. Intermittent angle closure is happening, but when you are seeing, it's not in a closer moment, but when you are not examining the patient, that time there is a subacute angle closure. Okay, so in that case also, because of that transient IOP spikes, you will be seeing, okay, there is progression. However, and most importantly, if there will be any vascular cause, like even anemia. Do you know anemia can cause glaucoma progression?
No, ma'am.
Okay, so this is something just remember. So whenever you will see patient is progressing, even if within the normal range, please go for systemic evaluation, including the blood test like anemia. Okay, so now it's coming to this. What should be the target intraocular pressure for advanced glaucoma? You are seeing a patient with advanced glaucoma. What should be the target intraocular pressure? advanced glaucoma? Dr. Shreya, what should be the target
7 to 10.
intraocular pressure for advanced glaucoma?
Ma'am, 8 to
10
12.
to 12.
8 to 12. 8.
It depends on the optic disc condition.
9 to 12 था ना?
Okay. Who else wants to say this is correct? 9 to 12. Okay, Dr. Gulati said. Anybody wants to answer? Anyone, wants to say, no, this is wrong. Any of the study that shows that, this percentage reduction is needed in advanced glaucoma? Dr.
7 to
Gulati,
10.
are you aware about any
Ma'am, I
study?
think
Yes, ma'am. Dr. Divya Prabha is already waiting. She is waiting. No, she is really waiting. I'll be finishing now. Just now. Last question. Yeah, no. She is already there. Yeah. Okay. So there is a glaucoma study. Which study says this much percentage of reduction of intraocular pressure is required for this type of glaucoma?
Eagle study.
No. It's EMGT, early management glaucoma, right? So as per that EMGT, the advanced glaucoma, you should be reducing 25% of your baseline intraocular pressure. But again, that is not what preferred practice is. Preferred practice is what? The intraocular pressure when there is no progression. It doesn't matter what is the number. Be it advanced glaucoma, be it whatever type of glaucoma, the target intraocular pressure is the pressure range from where the progression is not expected. There is no specific number. Clear? So we'll be discussing later on in preferred practice few other questions relevant to glaucoma. So now I will hand over. Okay. So in the meantime, let me ask you further regarding myopia. So what are the complications possible due to myopia?
Lattice degeneration.
Retinal
Okay,
detachment.
very good. Very
Retinal
good. Go
detachment.
ahead. Go ahead. What are the surgical complications due to myopia?
Myopic CNVM, myopic foveoschisis also can happen, ma'am.
Very good. And during surgery, any complication that is very specific to myopia?
Zonal
What type of
dialysis.
surgery?
Deep AC.
Okay, very good. If it's a myopic patient, then it will be a very deep anterior chamber. So obviously manipulation will be difficult. What else?
Weakness of
Weak zonules,
zonule.
weak bag.
Good. So weak zonules is also yes. Perfect. Go ahead. Next further.
Posterior vitreous detachment.
Yes, right. Posterior vitreous detachment is common. But I'm asking during surgery, what is
Ma'am, in
possible?
high myopia, the cataract surgery becomes complicated because of the deep AC itself.
Okay, so because of high myopia, yes. So what else? What are the other complications? Because if you'll be aware about the complication, we'll take care of it.
मतलब सुप्राकोराइडल हेमरेज हो सकता है इसमें क्या?
In the suprachoroidal hemorrhage is a complication of mainly due to increase hypertension, blood pressure, anxious patient, so that the blood vessel will rupture. So not in actually in a myopia. So if what are the complications? Let's be specific. In small incision cataract surgery, SICS. If you are seeing a myopic patient, what are the complications possible specific to SICS?
Thin sclera, so premature entry can be possible.
Absolute premature entry is possible, and also if you try to make it too much thin, superficial, also buttonholing is possible, right? So that's why. And when the chance of this, is there any relation in myopic patient SICS surgery you are doing and the location of SICS wound you are supposed to make, and why? Any relation of you are dealing with a myopic patient and it's a SICS, where the wound location should be there and why? Anyone doing SICS or assisting SICS?
So, ma'am, little further from the limbus, little.
Where are the SICS wound you have noted? Where it is possible? In which
Superior.
quadrant?
Superior.
Superior. Is there any other quadrant where the SICS wound is also done? Tunnel is done. Apart from superior, anybody has seen some other quadrant other than superior? Okay, Dr. Dibya is back. Dr. Dibya Prabha, are you back? Yes, temporal SICS is also done. So in myopic patient, because the temporal sclera is even more thinner, the chances of complication is even higher. Dr. Dibya, are you back? Okay. So might be, let me go to the next. Okay. So next slide, please. Okay, what is this?
Choroidal patch.
Posterior staphyloма.
Is there any specific name? In myopic patient, you will name this lesion. It is very specific to pathological myopia. Anyone?
This is the posterior staphyloma.
मायोपिक मैकुलोपैथी में
इस स्पॉट को कुछ स्पेसिफिक कहा जाता है, जो कोरियोरेटिनल डिजेनरेशन वाला स्पॉट है ना, उसको समथिंग इन मायोपिया यू कॉल इट. व्हाट इज दैट?
लैटिस
पेरिफेरी रेटिना में मिलता है, सेंटर में नहीं. डॉक्टर गुलाटी, व्हाट यू विल कॉल दिस स्पॉट्स?
Nail track degeneration.
टॉक्सोप्लाज्मोजी में.
Okay. Something else we're missing. Okay, go ahead, Dr. Shreya. You can show the name and yeah. Are you aware about this name? Anybody has ever heard about it?
Cracker crack.
That will come, yeah, what you are saying is also absolutely very good. That is also possible in pathological myopia. Dr. Shreya, I think you have another slide where that crack is very well visible. Can you go ahead for the crack? This is the Foster Fuchs. There is then the next, the second one Second not, it's the third one. Third image where you are seeing the lacquer cracks. Perfect. So now you tell me what is the significance of lacquer crack? If you'll see lacquer cracks, what is the significance?
Break of the Brooks membrane, ma'am.
Good. So what is the next complication? If the lacquer crack will be there, then what will be the next complication possible that you should follow up? Anyone? I think Dr. Gulati was saying the answer from the very beginning.
CNVM.
Yes, very good. Very good. So you should be careful for that. I think, for today, we have completed 30 minutes class for today. So we will be again meeting on Thursday. So all of